She spent many years in what at the time was called an insane asylum. And Mary Ellen recalls in her story being told that her mother was incurably insane when she was about the age of 8 years old. However, Kate began to reach out and develop peer support within the asylums that she was in, and the hospital became very uncomfortable with these meetings. She started gathering, and she was discharged at the age of 45. And she went on to have a highly coveted job as a nutritionist in an inner city high school. Mary Ellen talks about when she had died that lines poured out of the service building and around the corner. But this was very inspirational to Mary Ellen in the sense that, here were professionals telling her at a very young age her mother was incurably insane. And she, yet, despite those odds, goes on to live a very successful, well-connected life in the community. Mary Ellen herself then encounters challenges with mental health, and in particular, lithium toxicity due to the treatment. And that there began her motivation to find out what people like her mother and herself knew about recovery beyond what was currently being offered in terms of medication and therapy. But what else could we do? Believing that there was more. And this was the very early days. People were just at the very least starting to use the word recovery. And that's the roots of RAP and also the organization. So RAP emerged out of Mary Ellen's work, and as she began to work with other peers and offer educational workshops on recovery, RAP developed by a group of peers who have been dealing with difficult feelings and behaviors for many years, people working together to feel better and get on with their lives. As Mary Ellen had developed her written materials to go along with the workshop, she also developed her own publishing company, Rap and Recovery Books, which is now being operated by a company called AHP. The Copeland Center has been the organization, the nonprofit consumer-run organization, that has carried on the traditions and the practices of using these materials and continuing to grow an organization that is very grassroots, that's based in mutual learning. And I'm going to talk a little bit about the work that we have done in developing and implementing practices leading to substantial research. So first and foremost, when we talk about the Wellness Recovery Action Plan and who can use it, our focus has been that anyone who wants to create positive change in the way they feel or increase their enjoyment in life, anything from deep sadness, arthritis, hearing voices, diabetes, to burnout in our workforce. There are many professionals in the workforce that are finding the benefits of using a RAP plan for themselves so that they can be strong supporters to others by staying well themselves. So what is RAP? We're going to talk a little bit about the evidence-based, the practices of the Wellness Recovery Action Plan. When we talk about RAP and the evidence-based practice, we're talking about a very comprehensive set of work. That first set of work starts with the key concepts of recovery, well before there was any county government agency initiatives to define recovery. Mary Ellen was, and first and foremost, she began to conduct her studies actually through partnership with the vocational rehab at her state. Her rehab counselor and Mary Ellen had utilized the PASS program because Mary Ellen's plan for self-sufficiency was to research and develop this educational recovery that wasn't out there at the time. And that initial study she did was based on soliciting input from lots of people in recovery who identified with having significant mental health challenges to write in their stories about how they were managing, getting by. And from a few hundred kind of stories and journal entries that came back to Mary Ellen, she began to what we would call qualitative research. She began to organize them into piles. And through that, she found the emerging theme of the key concepts, starting with hope, personal responsibility, education, self-advocacy, and support. Today, we talk about these 5 key concepts as a foundation for all of the practices of facilitating RAP for people. Also, along with that, she discovered that people had lots of these very simple, safe, accessible things they can do for themselves. And then she gave this a name called the Wellness Toolbox, and set in motion what is today a continual project of collecting as many tools as possible from as many people as possible. Again, this began the second practice that the programs that we implement are based on. The key concepts, establishing this toolbox or wellness activities, if you will, that are identified by people in all the groups that we do. Actually, most of the initial educational workshops were based on the key concepts in the toolbox. And it was actually Jess Parker is the name of one of the group members in that workshop that really kind of stood up and said that my life is just so chaotic, and I wouldn't know where to begin with these key concepts and tools, and how am I supposed to use that to move forward. And after that workshop, Jane Winterling and Mary Ellen began to think about this. How are we organizing our lives to use these tools and practice these concepts? And it was there in which they developed what is really the core element of the Wellness Recovery Action Plan, starting with what's called the Daily Maintenance Plan, and ending with eventually what became the Post-Crisis Plan, a planned, structured approach that organizes these key concepts into practice and pulls upon these wellness tools in a strategic and individualized way. The fourth part of the curriculum are the recovery topics, things like building self-esteem, peer support, trauma recovery, and work-related issues. Now, today we look at those and think they're very common topics, but at the time, this was very innovative. And these topics were additional subjects in the workshops that people wanted more information on, that complemented the sessions. And there are a few of the key recovery topics that are actually were a part of the evidence-based practice that was studied. And we're going to get a little into that. So I talk about the key concepts, and one of the things that also evolved through this kind of peer network of peer recovery educators that has become today the Copeland Center and the Copeland Center certified trainers. One of the things that was noted was that some of these initial workshops would really not get at or have the feel of the spirit and the intention of this work. Keeping in mind that Mary Ellen's spirit starting this work was what are the things that we can do and that we're learning and we can get from each other to grow and move beyond the challenges of our mental health challenges. And so, again, one of the things they've really examined was how do we create an environment that actually is consistent with those key concepts? How do we invite people into a dynamic as a group that, for example, focuses on personal responsibility, a key concept of recovery, hope. And so from there, they began to develop the educator or facilitator, if you will, values and ethics. These people who are doing this work generated what were those beliefs and the practices that if are not upheld when you facilitate, or I would say engage people in this work, really change the outcome. And so today, the Copeland Center is strongly and firmly rooted in practices that are based on not, group therapy models or theories or, carrying in any other traditions that have evolved, but really, how do we facilitate in a way that is very consistent with these core group of values and ethics? The heart of great RAP facilitation is the values and ethics established by Mary Ellen and the core group of people who were passionate about sharing this life transforming process. I love this quote from one of our advanced facilitators who's actually a part of um, the research that led to the evidence-based practice. And he essentially said that these values and ethics, when we uphold them, bring the materials to life in our trainings. Just to give you a little sense of what these values and ethics are, is one here is that, all the things that we're doing should be based on self-determination, rooted in the belief of inequality, that it's a mutual learning model. So we often talk about facilitating a process, not teaching. That it's not a replacement for other kinds of therapy. That people have had successful use of certain therapies, and other people have not. And we really have to promote that people know what works best for them. My favorite value in ethics is that people, you are the expert in your own life. That also that in this work, although this is RAP, is we often talk about as a complement to your treatment and other supports that you have, this is not based on any philosophy or model, but can incorporate any philosophy or model. That this is really about a way of life, a way of living, a way of approaching daily challenges. We avoid medical and clinical language. Again, as much as this is a complement to those services in RAP, it's important that we avoid a focus on medical and clinical language. So I have kind of distilled down here for this presentation really what the key is to unlock the implementation of RAP and the evidence-based practice, what it is and what it isn't. And that is peer support and self-determination are two critical keys to understanding what has led to the evidence-based practice. And how the Copeland Center really facilitates is a process that has evolved out of two fundamental values, two different values than those in which the mental health field was historically based on. And these two values are, one, people are experts in their own recovery and wellness, that they have the expertise and knowledge. And again, understanding how this work emerged was really for a lack of the 90% of things that people need to do in their lives outside of the treatment they're getting. Mary-Ellen really explored, what is it that we need to do on a day-to-day basis for our own recovery? What are those things in which we do know ourselves? So that, the focus here is that people are experts in their own life. People with shared experience can support each other effectively. So again, self-determination and peer support. Now, this is not unfounded historically. I just want to share a little bit that, there has been a lot of work and within the mental health field on social modeling theory, and a lot of research and analysis of this over the years, many years predating this, but it just never really was leveraged or implemented in our system until recently. And social modeling theory essentially asserts this, that other people in similar circumstances, might have the most influence on behavioral change, right? And so this is a broad-based kind of psychology that was noted in terms of school and educational learning process, but as well as disability recovery. And this dates well back to, Albert Bandura and his work as a psychologist many, many years ago. Whoops, I advanced a little too far here. Also, a noted researcher, Matthew Chinman, he does a lot with the VA, took a look at the evidence for what we now know and talk about as peer support. And he essentially found that there are two levels of evidence out there, one of which is a high level, and that is a randomized control trial, which is where RAP falls into. But the large majority of the evidence out there for peer support falls into the moderate to low level, and that would be quasi-experimental, single group time series, and cross-sectional correlational studies. There's over 20 studies out there that really have shown that there is evidence to the effectiveness of peer support. Actually, both high levels and moderate to low, such as quasi-experimental, can also qualify for SAMHSA's evidence-based registry. So the research on services delivered by people who have themselves received services, so not necessarily even something that's defined as peer support, but simply having people who receive services get involved in, say, entry-level case management work, et cetera, has also been studied and looked at. And there has been studies that have shown that it has resulted in reduced symptoms of the caseloads, increased functioning, an enhanced sense of empowerment, recovery, hope, and quality of life for program recipients. And this dates back as far back as 1997, keeping in mind that that's when they have published the research. So we're talking about many years prior to that of data that they're collecting. Now, note the language that I'm using here is reflective of the time, things like increased functioning, et cetera, which is not very recovery-oriented language. Nonetheless, has helped to demonstrate in the traditional mental health environment that involving people with lived experience in the delivery of services is key. So the implementation science of RAP, which really is a peer-based practice that has achieved the highest rigor of demonstrated research. Most people these days know that. They know it's an evidence-based practice, and I'll talk a little bit about that. But what I want to share is, what I've kind of distilled into three levels of different studies, all of which were randomized control studies. There's one, the first, which demonstrated the overall positive outcomes and overall improvement in quality of life. And, again, this is the study that led to the evidence-based practice. And although the research and the main basis of implementation of the co-facilitated peer groups was based in the mental health setting, based on people with mental health diagnoses, one of the things I want to share in this presentation is that oftentimes where people started with the plans and the concepts of RAP, went the gambit of whole health. People didn't necessarily approach it, and it certainly wasn't presented as here's something for your mental health symptoms. Again, the target population, if you will, for the study and the venues were people who had significant mental health diagnoses and challenges. But historically, in my experience, is that where people start can be from any holistic point in their life, and indeed they have. So people can actually start with a plan to quit smoking, for example, but yet it demonstrated to reduce the symptoms that the studies were looking at. So the second randomized control trial study, which I think is a huge finding, was that exposure to the evidence-based practice model of RAP co-facilitated peer groups demonstrated a significant decrease in service utilization and self-reported need for services. So this is the big question when people have to look at investing to properly train people in implementing the evidence-based practice of RAP, which is a group model I'll go over in more detail, that it's a good investment because in the end, it has demonstrated that people develop their self-efficacy and are not needing and utilizing what we would call high utilizer services had significantly decreased. I'll talk a little bit more about that study in detail later. The third area is that people exposed to this RAP group model also demonstrated an increase in patient self-efficacy skills and behavior. Now, the fourth one was not a randomized controlled trial. It wasn't a study, but it was a program evaluation I want to touch on today. And that was where we implemented a RAP project with primary care coordination and health improvement for the community. And this was really a collaborative project to help bridge the gap between, primary care and mental health needs as well. So I'll talk a little bit about that. That project showed some really interesting findings. So RAP was selected for inclusion in the NRAP. That is the National Registry of Evidence-Based Program and Practices. a project of SAMHSA. And this is what it looks like if you go to nrep.samhsa.gov. Actually may look slightly different because it was just re-reviewed and approved again for it being an evidence-based practice. Again, I want to highlight that an evidence-based practice is an intervention that has been shown to be effective by causing predefined outcomes in people's lives when tested. And RAP was looked at from the viewpoint of significant mental health challenges in this initial study, although it has definitely demonstrated positive outcomes for overall quality of life and other health issues. What's important to note about the evidence-based practices when you look up these practices is that not all of them were at the highest level, such as RAP was, that it was a randomized controlled trial study. And that really places it at the most, I would say, an A+ as far as evidence-based practices go. So what did it show? RAP recipients improved more than control from baseline to 8 months follow-up on multiple outcomes. So again, it was also shown to have lasting effects, reduced psychiatric symptoms, especially depression and anxiety, increased hopefulness, increased quality of life, increased recovery, and increased empowerment, and increased self-advocacy. So what was actually studied? What is RAP as an evidence-based practice? Well, it's not just giving someone a book and talking about it. It was a group model that lasted for 8 weeks. It met for 2.5 hours every week. It followed a highly standardized curriculum, which is the Facilitator Training Manual, Mental Health Recovery, including Wellness Recovery Action Plan. And as I shared earlier, it covers everything from the key concepts to recovery topics. The practice that was studied had co-facilitated peers running them that the facilitators really adhered very strictly to the practices and the curricular topics and how much time you're to spend on each topic. Co-facilitators gave illustrations from their own use of RAP, which I think is very key to the engagement in the practice. They followed and reviewed a checklist of values and ethics, like we talked about earlier, such as medical and clinical language by the facilitators was avoided. The 8 sessions, here's a brief overview. I mean, we talked a little bit about this in the beginning when I talked a little bit about the history, but the beginning session started with the key concepts. Again, hope, personal responsibility, education, self-advocacy, and support are 5 key concepts that are the foundation of the course. And then sessions 2 through 3 really focused on personalized wellness strategies, i.e. Wellness tools and exercises to build self-esteem, and exploring peer support. Session 4 got into what I was saying earlier was the main core of what we now call RAP, and that is the daily maintenance plan, which is a plan for reorganizing and responding to symptoms and triggers that people encounter in their lives, establishing who your supporters are, how you want to use them. Session 5 got into early warning sign. And again, if you think about the values and ethics we talked about, one of them earlier I said is that people are experts in their own lives. So really, this isn't about pointing out to others what their signs are, but peers working together to share what those kind of subtle, sometimes internal signs are that when you notice them, they can be early indicators that things are going in the wrong direction, and we can take action to kind of counter those effects. And then we go into when things are breaking down, which is a time where we need to take more immediate action. And what's interesting is it's really important that you keep this individualized and that there's lots of participants sharing, because what may be an early warning sign for one person can be a sign of things breaking down for another. And then we get into crisis planning, which can be used and includes advanced directive concepts, but is not an advanced directive in of itself, because the crisis plan in RAP also focuses on how we can use natural supports to navigate a crisis too, not just what directives we need the hospitals to know. And then session 8 was the post-crisis plan. And actually, I want to kind of give credit to one of the peers as a part of the network here, Richard Hart in West Virginia, because initially post-crisis plan wasn't there. And he spoke up and said, a lot of us come out of a crisis, go back to our homes after the hospital, get so overwhelmed with things, and end up right back in crisis. So the post-crisis plan really looks at, how do we rework a RAP plan, what maybe we need to change in it, but also, what's the plan that we can have supporters help us, say, with bills and pets and certain things that we don't get overwhelmed with right away. So how were these outcomes assessed? Here are just some of the measurement tools that were used. The recovery assessment scale was used in the research study, empowerment scales, as I said, the patient self-advocacy scale, medical outcome study, a HOPE scale, brief symptom inventory, brief COPE scale, and mental illness stigma scale. And then also physical health perceptions were also looked at. So for the sustainability of fidelity, as I was talking about these methodologies that were used in the group, and how do we sustain and maintain those, there were key ingredients during the study that were obviously implemented with the intention of making sure the study was strong and ruled out compounding variables. But to this day, the Copeland Center and its practices really focus on maintaining some of these core ingredients. So there was a fidelity checklist reviewed after each session by, we don't, RAP experts here and the researchers, but, it's people who were using the plans, who were very familiar with the curriculum and who were the facilitators. And they were trained by the Copeland Center. Also, there were on-site observations conducted by RAP advanced trainers. And of course, when we say observations, these were not people who were just kind of sitting in the background or a one-way mirror or anything like that. But these were, highly trained and experienced people who have been practicing and living this curriculum and doing these workshops that were a part of the groups and ensuring that key practices of the methodology were being consistently upheld, like every session conveys a message of hope. And then third, there were weekly supervision calls between facilitators, local project coordinator, and research staff to review fidelity scores and address any drift. Today, what this looks like is that the Copeland Center works with partners and implements a vast network of facilitators. We hold webinars, we hold conferences, where essentially this is what we're capturing on a global scale, is that people are exchanging ideas, they're talking about how their practices are going, they're talking about where things are drifting, and how do we get back to center. So here's a little bit detail on the study that looked at service utilization. I think this is a really important study because as we all are trying to keep things funded, one of the big questions is how does investing in this practice actually save money in the long run? So the study that was conducted by Judith Cook and her colleagues, the impact of RAP on service utilization. Again, this was a randomized controlled trial, and it showed that there was significantly greater reduction over time in service utilization need. And the population of which was assessed was defined by individuals that were considered to be high utilizers of services, right? So this wasn't just looking at folks that were, tending to not use a lot of services in the beginning. But these were the big questions that the system also has is, people who seem to be cycling back to intense services and not seeming to make a lot of progress. It was a single blind randomized controlled trial study. The study looked at 143 participants. One group was offered RAP and others were offered the wellness nutrition group. The RAP groups were led by peers trained as facilitators by the Copeland Center. And the other group were wellness nutrition, was a wellness nutrition group led by non-peers trained in nutrition curriculum. So actually both programs demonstrated some positive impacts, but this study was really focusing on the impacts on service utilization. The measurement tool of service utilization and need was the support services indexed. It's a 19 services that were looked at using the support service index. Then it looked at a traditional array of services such as residential, medication management, case management, etc. So here's the study. You've got the RAP groups and trained methodology that are peers, and then you have a wellness nutrition group that are non-peers that are providing a different curriculum. Okay, in advance. So essentially what this demonstrated was that that people who were attending the evidence-based practice RAP groups had significantly reduced their utilization of services and was successful in that regard. So the next one that I said I was going to talk a little bit about was the patient self-advocacy. So now we have a study that shows this group is beneficial to reducing symptoms, increasing hope and quality of life. At another vantage point, it has shown that people become more confident in their ability to self-manage, so they utilize services less. And now this study looks at how do people interact in their medical appointments, how how much do they actually self-advocate as patients. This is really important to us because one of our key concepts when this work all began is self-advocacy. So this study basically looked at, there's 3 components to self-advocacy, 3 different levels. At the lower level is what is called education. This is the belief in the benefits of acquiring information about your health from your doctor and propensity to learn about the illness and treatment options. The second level is assertiveness. So that's the willingness to be assertive during a healthcare encounter in order to gain more information and appropriately challenge a provider's recommendation. And the third level is mindful non-adherence. And this is the inclination to actually disagree with your provider's recommendation based on your own medical knowledge, healthcare needs, and your personal beliefs and values, right? So this is actually the highest level. And at first it may seem like, well, this seems like the patient that's going to give you a hard time because they're not going to always follow your recommendations. However, lots of other studies showed that patients that practice mindful non-adherence, they're educated, they're assertive, and they actively participate in deciding what kinds of treatments they want, that these are the patients that actually have the best patient outcomes. And the result of taking a look at the impacts of RAP in a randomized controlled trial on self-advocacy found that RAP participants reported higher levels of overall self-advocacy. Among the 3 subscales, RAP significantly affected only in the mindful non-adherence. So in other words, didn't show a change in just the educational level, but significantly taking that educational level, as some people came in already practicing that, but they kind of came out of the RAP intervention now practicing mindful non-adherence. So higher self-advocacy was associated with greater hopefulness, better quality of life, and less severe psychiatric symptoms. Additional findings, the greater number of RAP classes attended, the greater RAP participants showed a reduction in symptom severity, reduction in symptoms of depression and anxiety, and increased quality of life and increased sense of hope. This is to say that as you may implement and develop the 8-week evidence-based practice model, and people don't attend all 8 weeks, it's okay. I think actually people attending as few as 5 of the 8 sessions still showed positive results. Obviously, the more sessions, the greater results. So I told you I was going to share a little bit about this. It wasn't a research study, but Mount Scottney Hospital and the health center is a critical access hospital of 25 beds in rural Vermont with patient-centered medical home serving approximately 20,000 people. The genesis of this project was the lack of access to mental health services in the face of community challenged by poverty and substance abuse. So the problem statement that was defined by this kind of committee was that coordinating care will continue to be a huge problem for professional providers and probably become more and more difficult as caseloads become larger and time constraints more of an issue. Also, they concluded that the likelihood of there ever being enough psychiatrists available means the majority of people will continue to get their mental health diagnosis medication from primary care. I don't think that this is specific to this region. I would say Pennsylvania, other states that I've traveled, this is a pretty generally true problem statement for mental health and primary care. I think overall, I think the primary care physicians said that they feel that one level or another, about 70% of their patients have some mental health complaints, and they don't really have the resources to tend to that outside of prescriptions. But beyond that, primary care feels a little stuck in responding adequately to the complaints that they hear that are mental health related. So for this reason, self-management skills and recovery programs for patients and their families are critical to overall well-being for the community and its members. The Rural Health Outreach Grant basically took a strategic approach. They did a needs assessment, formed a coalition consisting of mental health, administrative, medical staff, evaluation experts, working with support and technical assistance from HRSA and Rural Health Outreach Program. And then they researched best practices in the realm of self-management, and that's where RAP was entered into their approach. Participation was strong and growing. 53 people took the 3 introductory trainings. It was a record number of participants for any of their educational initiatives they rolled out. Benefits were sustained. Benefits were achieved during the training, were sustained as long as 9 months after the end of the RAP trainings. And Mount Scottney's capacity to meet the mental health need was improved. Primary care providers credited the RAP and community health team with creating environments of help and support for patients that allowed their mental health need to be met more effectively. This project was led by our Vermont coordinator, Jane Winterling. As you heard me mention earlier, Jane was the one who was shoulder to shoulder with Mary Ellen when they actually developed RAP. One of the really interesting findings of this was that people cited that those who attended the RAP groups actually began to participate and attend more of the other educational workshops that they were providing. So it was a real kind of complement enhancer to a lot of the other great services that were being provided, educational services, et cetera. So for many of the folks, they weren't anticipating that by people participating in an additional group called RAP, that it would actually result in greater attendance in the other workshops that they were offering, but it did. So what I feel is really critical to the activation for whole health is this peer group dynamic. As I said earlier, promoting self-determination really means that we're not there to teach, but to facilitate, and that means specifically how do we generate ideas from group discussion, where people are learning from those in which they're connecting with based on shared experience. That as we approach this, we don't approach this as a predefined or a clinical approach. So it's very important to allow people to begin where they are. So for example, I find it very effective as we're talking about the key concept of hope, starting the workshops, really inviting people to think of what they hope for in terms of their wellness in their life right now. And that often allows people to start making the plans from what's most important to them. A lot of the younger populations, as we're doing RAP for high schools and youth around the country, they don't want to talk about managing symptoms or these types of things. They're really focused in on, jobs, intimate relationships, education, and where they're going to live. And that's where they want to start. And that's where a lot of them start with their plans is those areas of their life. A third element here is empowered. People are empowered because it's a voluntary approach, and people connect and get drawn in based on a connection of shared ideas that people who are really reflecting back to them, similar experiences. But that it's very key that people can participate at any level that they really want to, and they feel like they're not coerced or in a RAP group because it's contingent upon something else. And again, plans start from life goals, not clinical goals. So how does this kind of capacity grow? And what work we're doing together in Maine here is really looking at these key steps the Copeland Center has been implementing to maintain the evidence-based practice and allow communities to sustain it. The first step, and I like to say that, if you think about RAP more like yoga than just a psychoeducational information dissemination. That the first level is you attend a seminar one, a group yourself, where you're applying the techniques in your own life. Seminar one is designed to facilitate people to develop their own personalized plans and strategies based on the 8-week, 2.5-hour agenda. And again, it is co-facilitated. And this is something we are working with Scott and Paula as they are trained facilitators to model and implement. The next level is seminar two, and that is, as I kind of said before, it's, this would be like now you've gone to yoga groups, you're practicing yoga in your life, and now you want to become a yoga instructor. So this is the facilitators course. This is designed for people who are using RAP. This is where you'll learn about the values and ethics in facilitating, or the methodology, if you will. It's based on a 5-day agenda, co-facilitated by Copeland Center for Wellness and Recovery trained advanced level facilitator. Again, Scott is an advanced level facilitator and will be working with me to provide this around Maine so that there are more facilitators who go back on their local level and maintain the evidence-based practice. And then, I don't know why it says number 1 here, it's number 3, advanced level RAP facilitator certification course. This is the course that is maintained for quality control by the Copeland Center, is designed for experienced facilitators to learn how to mentor peers in the values and ethics of facilitating RAP. This is the course that when people take the advanced level course, they can go back and train other yoga instructors or RAP facilitators. Again, this is not yoga, but it's a better analogy than looking at some of the psychoeducational courses where you're just simply talking at people, giving them concepts. It is really about how do we engage and model that this is a practice that we're doing ourselves. So here's also some basic keys to implementing this work. 1, support at least 2 certified RAP facilitators to organize a presentation or a group, right? So Paula and Scott, right? So organize them. Attend it yourself and develop a RAP plan in this group. Use your plan as much as possible, and then take the 5-day facilitator training. Then organize a RAP group where you can help others use RAP. So you do not have to have a diagnosis of this kind or that kind. As I said, people actually don't develop their RAP plans around their diagnosis. They wrap them around their life. So we have many folks that have sat in a RAP group, developed a plan for themselves to not burn out in the workforce. They take the facilitator training, they go back and they offer it to their peers and colleagues in the workforce because, we're working 40 to 50 hours a week at a very difficult job, and seeing people at their worst, and we need to be well too, right? So we have many people who are doing that as well and using this. In many ways, what I've heard is people who are working in the mental health field say that this is the recovery to practice training that they've been looking for. Practical application of these concepts, that's been missing, not just changing the verbiage on the signs of our services. So at an agency level, if you're directing an agency, here are some best practices. Finding ways to facilitate formal and informal RAP group opportunities. So, ways to work it into the part of service offerings, but also looking at developing volunteer initiatives, grassroots initiatives, kind of being a catalyst, or even just making sure that you're offering them after hours. But maybe eventually the peers that were receiving services that you're offering RAP to become facilitators, and you help them set up their own groups through churches and coffee shops, and now they have a natural support using RAP in their life as they transition out of your services. Develop and foster a network of facilitators. So as an organization, you can, as you're training facilitators and you yourself may become an advanced facilitator, how do we participate and create structures where those facilitators, like the Fidelity model showed, can work together, check in, and avoid drift. Focus on RAP as a process, a way of life, and a mutual learning process, not a document or a form to be put in charts or a file. It's not a kind of check off your triggers and your action plan sheet and put it in the file type of thing. Not the evidence-based practice. Probably won't work very well. Probably give RAP a bad name if you do it that way. But really that it's a way of life, that we're modeling it, that we model that it's for anyone, and wellness is all equally important to everybody. Be all-inclusive, create atmospheres that is based on our common human pursuit of wellness, not a diagnosis, illness, or deficit orientation. So I've seen it really successful where we implement RAP Seminar 1 groups with the primary benefit of people receiving services, but we also have the case managers and other folks in the room together, and everyone's just sharing ideas for their wellness. Actually really improved a lot of the rapport between the service people delivering the services and receiving services, and it really kind of shattered the us and them environment that had existed there. So great way of going about it. Incorporate RAP concepts, values, and planning process on multiple levels of the organization. So for example, the Copeland Center for Centers of Excellence that we have certified, we actually do kind of building team wellness using RAP, where we're looking at, to be a well member of this organization, what are my tools? What are my triggers? What are my action plans? Sharing that with each other has been really hugely beneficial. So at the same time, people are strengthening their knowledge of RAP. They're also doing an amazing team building opportunity. Maintain the voluntariness or self-direction of RAP. So it's really important that, in our service delivery and in our presenting of RAP and the work that we're doing, that it's a very strong message that this is voluntary, that these plans are for you, only you can develop them, you can share them with whomever you want. It's not about us getting something into the chart, although it's very beneficial for your crisis plan to be very clear and informative to those that are going to be involved in a crisis. And then also making sure that we're accommodating a variety of learning styles and settings. So, allowing people to do some self-start, self-taught things, distributing the books and letting them read them and decide whether, and when they're ready to join the group, but definitely discerning the difference between evidence-based practice and just reading the book. Offering groups, like we're doing here, webinar. This is going to be recorded so people can also listen a little bit and hear how this program is different than some of the other programs they've maybe used. Using arts and crafts, so not just relying heavily on the books and the written words, but allowing people to cut out pictures, to use creative expressions for their wellness toolbox and what hope means to them and stuff like that. Wrapping up here, we have a document that is kind of an advocacy white paper document. It's free and downloadable at our website. It's called The Way RAP Works. We developed this over a number of years, hearing from RAP facilitators and advanced facilitators about what the challenges were and what were the things that are really important to inform behavioral health, mental health systems about, how RAP should be implemented to really adhere to the values and ethics and the evidence-based study. So this document is a pretty comprehensive overview of potential pitfalls, ways to successfully do this on a systems level, and was developed by people who have been doing this work for 10 to 20 years. So it's a really useful document when thinking of how to plan this out or becoming a facilitator to be familiar with it. Also want to let people know we are having our Wrap Around the World conference in Sacramento, California. We generally have anywhere between 500 to 600 people from around the world. This year, we will be having the CEO of a very large psych rehab organization in Hong Kong, who's also now a Centers of Excellence for RAP there, because they have a team of like 20 advanced facilitators. They're training trainers. They're spreading RAP into even the high school teachers are developing RAP for themselves there. She will be keynoting at the conference. Very fascinating lady. And if you become a member of the Copeland Center, you'll receive a discount on the conference rate as well. Just want to say thanks to the U.S. Department of Education, National Institute on Disability and Rehabilitation Research, and SAMHSA and the Center for Mental Health Services. These are the groups that really helped fund the initial studies that led to the evidence-based practice many years ago. And here's where you can find out more information. You can go to thecopelandcenter.com. We also have a National Consumer Technical Assistance Center called Doors to Wellbeing. And you can also find out more information about the RAP study at www.cmhsrp.uic.edu. Judith Cook, the researcher that led the research for evidence-based practice, is at the University of Illinois in Chicago. And this is a really great little study about evidence-based practice, and it used RAP as the example of what goes right and wrong with implementing actual evidence-based practices. And then for all your publication needs, you can go to rapandrecoverybooks.com, which is a website of AHP Advocates for Human Potential that pretty much owns and operates all the publication materials based on Mary Ellen's work. With that, I think I've allowed some time for questions.
Thank you, Matthew. We have one. If my supervisor wants to know why they should send me to RAP facilitator training, what should I tell them?
I think we have a duty in terms of mental health organizations, receiving public funds and serving people with mental health to really provide the very best to people in recovery. And in particular, if we want to be offering a highly demonstrated evidence-based practice that has shown that people will decrease their utilization, get positive benefits, the facilitators training is designed to ensure that we're implementing the actual evidence-based practice and not just using the name of it actually. This is going to be recorded, so I'd say listen to the recording too, and maybe that will help understand the benefits of getting the training to properly provide the the intervention, if you will.
Okay. I don't know whose phone was mute, so if you need to speak, please let me know, because I did mute too. Are there any questions? We still have a few people with us. We have one from Lydia. Will this training be different than the training provided early on before the Copeland Center?
I'm not sure the meaning of the question. This training meaning this webinar?
The RAP and the RAP facilitator training.
The RAP facilitator
workshop.
Yeah, the 5-day facilitator training is substantially different than the Seminar 1. The Seminar 1 RAP courses that have generally been provided really focus in on how do we develop RAP for ourselves. In the facilitator training, it's expected that people are already familiar with the plans, they are using them, and so it's a very experiential process of learning the values and ethics, learning about how we share our RAP to offer the RAP training. So it's really more about those values and ethics, these 15 core values and ethics. There are 4 practice elements in the course where people get an opportunity to practice facilitating and specific techniques to facilitating. Sometimes this is where people realize the facilitators that did their workshop departed slightly from practices because they come and they learn, here's how we're supposed to introduce the welcoming, etc. So it's substantially different. A lot of people say they didn't really start living RAP deeply until they took the 5-day facilitator training and learned about the values and ethics.
Right. And these trainings that the Peer Training Network will be offering, you take both the 4-day RAP workshop where you do your own RAP, and then you take the 5-day facilitator training in like 2 months afterwards, and they are working together so that you've had some time to work your RAP and use your RAP, and then you take the facilitator training, and it's all working within those ethics, and it's really super different.
Yeah, and I would add too that having done a lot of different types of groups and educational workshops, and you'll find that in this 5-day facilitator training, you're learning RAP more deeply, but you're learning group facilitation techniques that I think you'll be able to use in any type of work. I've even heard people say that they start to implement using the values and ethics with their children as parents, or in their relationships. So again, this is the course that a lot of people say is the real recovery to practice training.
And if you have a RAP that you've been using for a while, what I find that every time I do a RAP training or I sit in on another RAP group, I get something out of that group process. Matthew talked a lot about the evidence-based practice, that it's about the group, that you co-learn from the group. So by taking the RAP over again, the RAP workshop, that 4-day training, you're going to get more out of being in that group process, and a reintroduction to the way it should be taught with the Copeland ethics and values.
Yeah, and I would say,
I hope that's answering people's questions.
Yeah, and if you've had RAP and been using it for 20 years, it would be fantastic to have you in the facilitators training. You will, you'll find that you can really focus in on the facilitation and the values and ethics part of it. To where sometimes people, they've only been using the RAP for 3 months, and they take the facilitator training, and they have to do a lot of work to really strengthen their knowledge of RAP. But if you've been using it for 20 years, then you can really focus in on the facilitation skills that are really the focal point of the course. So you would be wonderful to have in this course. It'd be an ideal candidate for the training. But like Lydia, like Paula said, for me, doing this work all the time and having been doing it for 15 years, not quite 20, but that I'm constantly updating my plans to new areas of my life that I learned from doing these groups. My life has changed a lot in 15 years. I wasn't a parent when I started. And so, being in these environments with other peers allows me to kind of get the support to just focus on new plans. So I think you'll find that's generally what's going on for a lot of people too. They start off with an initial plan, and that's what RAP is to them. And then they come to this course and realize, wait, I could be applying this key concept to hope to my next venture in my career, or a whole other level.
Do we have any other questions?
Thanks, Craig. You're welcome.
Thank you, Craig, for being on the thanks for watching. And here's the Peer Training Network contact information. And if anyone needs to call in and ask questions, please don't hesitate. And I hope we get a lot of people signed up for the upcoming trainings. And remember, we've got one coming up in Bangor in June for the 4-day RAP, and then Seminar 1, and then in September it will be the 5-day RAP facilitator training, where Matthew will join us. Thank you, Matthew, for joining us, and
Yep, thank you for having me.
That was wonderful. Thank you so much.
You're very
Thank
welcome.
you, everyone.
Thank you.
I know.
Bye-bye. Thanks.
Bye.
Bye-bye. Thanks.